So CABANA is a trial that most people have been waiting for a very long time. Recruitment was difficult, predominantly because where do you find the patients from? Most people who've been referred to an electrophysiologist have already gone through a lot of treatment, they've started medication, they've failed medication. And so when they get referred to a cardiac electrophysiologist, it's for an ablation. So we tried to recruit, and it was actually very difficult. So also when you go to A&E to get someone who's not been on medication and suddenly start offering them an ablation, again, it sort of comes out of nowhere. So it's a trial that took a very long time to recruit. But fair play to the investigators and Doug Packer. They were able to recruit a large number of patients. It's the biggest randomized controlled trial that we have for AF ablation. And they chose a challenging endpoint of all-cause mortality as the primary endpoint. As the trial went on, they changed the endpoint and made it a bit broader with a composite endpoint, including stroke as well as death and cardiovascular hospitalisation. And then finally, it's now we now have the results. The difficulty is, as this was a proper randomised controlled trial, it's reported intention to treat, as it should do, but there was a large number of crossovers. So 30% in the drug group actually ended up with an ablation, and 100 people or so in the ablation group didn't have an ablation. Now, once the paper comes out, we'll be able to interrogate and investigate exactly why there was such a huge crossover rate, especially in the ablation arm, of people not getting ablated. And so the headline is that it's a sort of a negative or a neutral trial if you're looking at it from the point of someone who likes doing AF ablations. However, if you then look at what treatment people received, then those who had an ablation, there was a mortality benefit, the composite primary endpoint was reached, it was a pre-specified decision to make that analysis. And so people can probably take the trial in whichever way they want to. I think a lot of people will use this as saying, look, ablation is really worthwhile, and it will give them more to talk about. I think people who are slightly critical of the AF ablation field will use it to say, look, there's no difference. And if anything, this will spur further trials. The other thing to realise is it was a very mixed group of patients, paroxysmal and persistent and long-standing persistent, and also the trial, because it, the time it's taken to be done, the way that people do the ablation, the lesion sets, and the technology that people use has changed dramatically over those sort of 8 years. And so, is it even applicable to how we do AF ablations now? So I think there's a lot of questions. I think people will basically use it to reinforce what their view was already. But it's what we have, and that's randomised controlled trials for you.